this full screen. Oh, that picture is super blurry, but okay.
Much better.
Alright, so this was unknown number 1. So this one has pretty normal, orthokeratosis, and really your pathology is in the epidermis. You have these kind of bulb-like downgrowths coming down from the epidermis, or kind of dirty feet, if you will. So these are characteristic of a solar lentigo. And so if you went on higher power and went looking, there's usually an increased number of melanocytes to go along with it. So the kind of dirty feet is the buzzword for the solar lentigo, where you have those sort of bulb-like downgrowths of the rete, and it can start bridging, things like that. There's really, I think, clinically and under the scope, sort of a continuum where, the reticulated seborrheic keratoses can kind of start developing that look, but they tend to have the, horn cysts and some other distinguishing features, but I think they're kind of on a spectrum, because clinically, a lot of times there's overlap as well. But the first one was just a solar lentigo.
Can we just look at the papillary nerves a little closer? Sometimes I kind of like to see at least the hint of solar.
Yeah, and there probably was, but this is, again,
so pale,
kind of
right?
an old slide.
Because you also have to consider lentigo simplex.
Yeah, it doesn't have quite the same.
Right.
Wow, that's really blurry. Kind of bulb-like architecture that the solar lentigo does. The other cut was a little bit better there. You can start to get it there. I think all the scopes are so different. It takes me a little while to figure out. Still marginally better. Alright. Alright. Number 2. Let's look at this on scan first. Oh, sorry. Yeah, I bumped it. Okay, so what you see on this one is, if you look at this lateral edge, so when you're looking at melanocytic things, one of the first things you always want to look at is, is it well circumscribed? Is it symmetric? Is it maturing? So this is a pretty big lesion, but if you look laterally, you can see it really is pretty well circumscribed. You have kind of the more thin epidermis there, and then you start getting into your kind of raised, what's clinically probably a dome-shaped lesion, with a little bit more papillomatosis, and it's big, but again, on this side you can see it ends pretty abruptly, and just looking at it on low power, it does look like it matures, it looks a lot more dense kind of superficially, and then as you go deeper, the cells are starting to get smaller and smaller nest till they get to be kind of singlet in the bottom. You can really kind of see that on scan with this one. So same thing, you've basically got these nevus cells that are filling the papillary dermis and kind of pushing up against the rete, so you get flattening of the rete, but they're nested up top. Nested up top, and then as you're going down, they're getting smaller, and they're kind of starting to get smaller and smaller nests until they're on their own towards the base. So that's nice maturation. So this one has all friendly features. It's just a benign melanocytic nevus. Got some melanophages mixed in there.
Did they mention if it was congenital or not?
They didn't, but that one looks congenital. Okay. So Dr. Elson always says, however it goes on the scope is how you leave it. So we'll look at this one upside down. So this one, similarly, if you look laterally, it looks like it's, again, a dome-shaped papule. They didn't get all of it with this, so it goes to one edge, so you can't really tell the overall symmetry architectural-wise. But if you look at it from top to bottom, you have the more kind of larger nested areas up top, and again they cut it off so we can't see the whole thing, but it does look like it's starting to get smaller nests, and then in this one you can see a smaller nest towards the bottom. But really what he wanted to highlight with this is again just a benign melanocytic nevus, was he wanted to highlight these pseudovascular spaces, and once they've been pointed out to you, you'll start to see them more and more in other nevi. They can, if you start looking at them, you can kind of out and worry about an angiostart, but these are in a lot of melanocytic things. So, sorry, there we go. We had a consult case last week that had these in a Spitz, which made it look kind of concerning because you had nevus cells floating. It looked like a vascular space. It was kind of an atypical lesion anyway. So if you go on higher power, you can see that it's not a true vascular space. There's no endothelial lining. Those are all just nevus cells. So this one basically was just benign melanocytic nevus highlighting the pseudovascular spaces. And in some of the other nevi, you will definitely see these now that they've been pointed out to you. So in nevi, too, a lot of times if you go on higher power, I think the table is like rocking or something. If you go on higher power, you can see a bunch of multinucleated cells, and that's normal. You can see those in nevi. You can see mitoses in nevi, especially in kids when you have growing nevi, but the mitoses usually are going to be limited more to the upper dermis. If you have deep mitoses, then that should raise a flag to look a little closer, because you can get nevoid melanoma. So this one, I think, picked because I think it's like straight out of this entity. They classically describe a wedge-shaped architecture where the base of the wedge is going to be pointed up towards the epidermis, and then the apex is pointed down towards the deep dermis. These lesions often extend into the deep dermis, sometimes even down into subcutaneous fat. And you have a mixture of spindled melanocytes, melanophages, and epithelioid cells, which we'll see when we go on higher power. But from this power, you can definitely see the melanophages, and some of those spindled melanocytes mixed in have, melanin granules in their cytoplasm too. All right, so let's see if I can get the arrow to work. There it is. So you have a lot of these melanophages, and then let's get it on higher power. I'm not sure why it keeps getting out of focus when I go to higher power. Okay. So you have all of these melanophages, and then mixed in you have the more kind of pigmented, spindled dendritic melanocytes, and then you also have these more epithelioid looking cells. There's one, there's one. So normally this is a deep penetrating nevus, so normally with these you have a population of the spindle dendritic melanocytes intermixed with melanophages, and those are the predominant cell, and then intermixed you have smaller populations of those epithelioid melanocytes. So a lot of times, so there's like a superficial variant of this, which if you get it, some people just call it a combined nevus. We had one the other week, where you see those kind of the different population of the more epithelioid looking cells in the background of kind of a blue nevus-y looking background.
That's helpful because we struggle trying to understand the difference between those two, but now that you say that, that makes more sense.
Bless you.
There's some authors also call them plexiform, but it's the same.
Yeah, they call them like plexiform spindle cell nevus or something. Yeah.
It's just really confusing.
Okay, so speaking of combined nevi, so when you use the term combined nevus, you basically just mean there are two different populations of nevus cells. You can have any combination. They say the true and blue is most common, where you have a combination of a true, intradermal nevus or compound nevus and a blue nevus. So true and blue is most common, but you can have any variation. I mean, you can have a Spitz combined with something. You can have a Spitz and a blue, a Spitz and a you can have any combination. So this one at scan, you can definitely pick out the blue nevus component, right? So you have the more, spindled or dendritic melanocytes, you have some melanophages, and then it does look like you also have a different, especially around these hair follicles, different population of cells. Right, so to me these just look like more classic nevus cells. And this may have been a congenital nevus because it seems to like to be around the nexal structures. And then here you got your component of blue nevus. So you can see the more, this to me is a little better to see than in the other one, because the other one had so many melanophages, they're kind of overlapping, but you can see the nuclei, and then you have the long kind of spindled dendrites. So these are your blue nevus melanocytes, and then blue nevi also will have a kind of sclerotic stroma, which Dr. Elston will probably point out on Monday, that you can do the kind of poor man's condenser when you get if you're trying to decide between a blue nevus and a blue nevus like melanoma or malignant blue nevus. The blue nevi will have a distinctly sclerotic stroma, and so when you put your hand over the condenser, sort of all the other collagen lights up, and then the sclerotic stroma doesn't, so it's separate, versus the malignant blue nevi and the blue nevi like melanoma tend to not have that much of a distinction. It's a little more kind of blurred, so it's sort of one way to help delineate, because those to me are very challenging. But so this one was just a combined nevus. Yeah, this looks like it probably was congenital. Okay. Number 6. Alright, so this one at scan you don't really see much, or when I was looking at it initially I didn't. So then you go on higher power, trying to figure out what the pathology is, and you start to see these really nice spindled melanocytes. Let me see if I can zoom in even more. Okay. So, see this guy? If I focus in and out, you can kind of see his dendrites a little bit better. They're really, because spindled look to it, almost looks like a bow and arrow or something. And then you got one up there, and then there weren't really that many, but there are a few more over here. Let's see. Looks like a melanophage there. Oh, here's one. He looks like a boomerang. That little spindle melanocyte, you got one there. So this is a Nevus of Ota or Nevus of Ito, it depends on where it's from. I think they call this one Nevus of Ota. So clinically, Nevus of Ota is going to be around the eye, it's congenital, and then Nevus of Ito is going to be more kind of around the shoulder region, but they look the same on PAT. If you have an acquired one that you develop later in life, it's called a Hori's nevus, but it looks similar. And so usually with the acquired Nevus of Ito, Nevus of Ota, you're going to have these kind of spindle dendritic melanocytes that are going to be in the kind of upper to mid dermis versus a Mongolian spot like you see in babies with darker skin. Those will have the same kind of melanocytes, but they're usually are deeper in the dermis. But clinically, it's a hyperpigmented patch, basically. And I think sometimes if you have kind of a darker area within it, if you biopsy that, you can see larger clusters of like melanophages. But if you just get the more faint kind of background hyperpigmented patch, it should just be more of the spindle kind of dendritic melanocytes like this. Pretty subtle, but hopefully you'd have clinical to go with it. So this one, again, I mean, for me, I just try every time I look at a melanocytic thing to think, okay, is it circumscribed, is it symmetric, you know. This one looks like it ends pretty abruptly over here. This side looks like it ends pretty abruptly also, meaning you don't have like that much kind of trickling out. It's not, you know, ill-defined, if you will. And it looks like this lesion was probably papular, right? It's kind of a dome-shaped papule. And so this is a Spitz nevus, and things you want to look for when you're looking at a Spitz nevus, you know, is it symmetric? Is it well circumscribed? That, you know, some people find that helpful. There have been some people that argue against that in terms of spitzoid melanoma, but Dr. Mays always, you know, talks about that when he looks at the atypical spitzoid lesions he gets sent in consultation. And so these used to be called spindled and epithelioid neoplasms before they were called Spitz, because they're made up of sometimes just spindle cells, sometimes just epithelioid cells, but a lot of times a combination of both spindled and epithelioid cells. If you go in and look on higher power, they're usually going to be arranged in sort of nests and fascicles that look like they're sort of raining down off of the epidermis. And because of the artifactual, because of processing, they get a lot of times these clefts around. You can see one kind of right there in the center of the field. They get these clefts around the nests or fascicles of the nevus cells. And then also you're going to a lot of times have kind of a PEH, like a thickening of the epidermis, pseudoepitheliomatous hyperplasia. A lot of times will go along with these. And you don't always get camino bodies. A lot of times you have to step section to see them, but if you do get them, it's helpful. So it looks like we have one right there. We'll go in and look at it. And so with the camino bodies, they basically are basement membrane. And they're usually along the DEJ. So there's one right there. Starting to form one right there. So if you see those are helpful for identifying this as a Spitz. You can also see them in pigmented spindle cell nevus of Reed, which some people lump that in under Spitz, and some people don't. There are some subtle differences. Spitz nevi, to me, the cells, if you go in and start looking at them, sometimes can be kind of scary looking. But in melanocytic things, especially in Spitz nevi, it's okay to have those prominent nucleoli. Like you can see them from this power staring back at you, and the Spitz cells will often have those. Okay, so this one has a fair amount of pigment incontinence, but there's more of that kind of artifactual clefting here. And if you look at these, like within each nest, the nuclei all look pretty similar, right? They're all kind of similar size, doing the same thing, and they're pretty cohesive. You know, the splitting is just artifactual. So this is just a benign Spitz nevus, and then you get maturation in these too, right? So they're bigger nests up in the epidermis, and then as you go down, they're getting to be smaller and smaller. Spitz are usually biopsied in kids, and so everything in kids is growing, and so you can see mitoses in Spitz, especially higher up, you know, especially if it's a kid. So I think what's considered more worrisome is if you see mitoses in the deeper component for these.
There's one right there, towards 12 o'clock. Well, I'm sorry, in the arrow it would be
right there.
9 o'clock. Yeah, there's quite a few.
Yeah, and so I mean, that's like, I was looking through unknowns recently, and there was this big congenital nevus, and it looked like it had, for all the world, melanoma in situ over the top of it. I mean, it was terrifying looking. I took it to Dr. Mays. He's like, it's from a kid. So, I mean, there's sort of special rules for kids, especially newborns. Apparently, if you biopsy their nevi, they look crazy because they're in such an active phase of growth.
Like, how young do you not worry about something?
So Whedon said newborn, which I feel like that is sort of ambiguous. Dr. May said that he sees that kind of activation all the way up to a year in kids. But just the mitoses and the growth you can see in kids probably up to puberty, just because the moles grow with them, you know.
When they have the giant congenital nevi, sometimes they have an area that's more bumpy and growing. They call them proliferative.
Yeah, so those are a whole
really
nother.
scary.
Those are a whole nother beast. Yeah, so those. Dr. Winley, our pediatric dermatologist, has a number of those patients that she follows, and you have to follow them pretty closely with serial photographs because the nevi at baseline can be sort of lumpy, bumpy, because probably if you biopsy them, they'd have a lot of like papillomatosis. So you have to really closely monitor for any sort of nodule and biopsy it, because they, especially in the giant congenital nevi, they do have an increased risk of melanoma over baseline. But they also get these dermal proliferative nodules, which can be like full of mitoses, and they're like they're terrifying to me. I mean,
I'm really scared.
so yeah, I hope that no one sends one of those to me.
I don't envy those.
Alright, so that one was just the Spitz nevus. Let me just speed it up. They just called that one. Alright. So this one, basically he just wanted to highlight that this is a nevus from special site, right? Because you look at this and this doesn't look like your standard run-of-the-mill nevus, right? And it also doesn't really look like your standard Clark's nevus. But it doesn't, look that concerning either. So they didn't get all of it, so we can't really comment on the overall, symmetry of it. But, so Dr. Elson likes to use the analogy of, when you're looking at it, does it have a regular kind of set rhythm, so the placement of the nest, or is it a Latin beat? So his Latin beat is his melanoma. It's sort of a, nest, and then it's just kind of irregular. You'll hear him say that. This one does look kind of irregular. Like over here, you've got a huge, nest in the epidermis, and then smaller one, a little bit of bridging. It's just not really following the normal nevus rules, and that's okay in certain sites. So any kind of genital nevus, nevus on the buttocks, acral nevi, now they include ankle nevi, ear nevi, acral palmosole nevi. So there are a bunch of different special site nevi, and they all are allowed to have a little bit of kind of a funky architecture. And conjunctival nevi, what Whedon says, is basically just what you see, like take that down a level, because they always look funny, the conjunctival nevi. But I know, I think specifically like the nevi and the genital region are allowed to have these really big nests of cells, and that's okay, kind of like what we see here. I don't know where this one was from, they just call it a special site nevus. But we've seen some funny looking ones on the ear too, and so you can allow for that. And a lot of the special site nevi will also have some pagetoid scatter, which you can also, I didn't mention, see in Spitz nevi. In Spitz nevi, the pagetoid scatter is usually nests of cells, like 2 or 3, rather than single melanocytes, and it's usually in the center of the lesion, not at the edges. There is an intraepidermal Spitz nevus that's only an epidermis that can look like MIS or Paget's, because it'll have these kind of epithelial-looking cells sprinkled throughout. So that one's another beast. But again, it's usually more nests of cells, but it can have single cells. But for these special site nevi, it's kind of the same thing. They're allowed to have some pagetoid scatter, but it's usually confined to the center of the lesion and not trickling out to edge like in MIS.
Did they say which site this was?
They did not say for this one.
It's very thin.
Yeah. So this one, similar to the one that Dan pointed out earlier, is a congenital nevus. So see those pseudovascular spaces? Now that we've pointed them out, you'll see them a lot. So this one again, it ends over here, so they got it out. It ends right there. This one is predominantly intradermal. There's not really as much kind of filling of the papillary dermis like we had before. But if you look at it, you've got cells that, you could draw a line across the bottom. It's not infiltrating, if you will. And you have nests of cells up here, and they're getting smaller nuclei-wise towards the bottom. So what makes this a congenital nevus, or features of congenital nevi, are they tend to be kind of periadnexal. You can see them sometimes in like the sebaceous glands, around the follicles, in the eccrine glands, in the erector pili muscle, and sometimes they'll also splay out in almost kind of Indian file. Whereas, you know, the regular run-of-the-mill intradermal nevi are not going to do that. And around blood vessels. I didn't include that. They like to be around blood vessels too, like you can see here. This one doesn't really have good Indian filing, but there's another one. I feel like clinically a lot of times the congenital nevi have hair that stick out of them. And the right ones. Alright, so this one really nicely demonstrates the circumscription, right? I mean, you can actually almost envision that this was a little clinical papule, right? It's out. They took a very large biopsy of it. So at scan, there are a lot of lymphocytes in the background, but you can kind of see more of a pinky component. So if you go in and look, you know, you can more clearly see you've got the more kind of pink cells, and then the lymphocytes kind of all throughout this thing. And then here you got like a nest of cells kind of hanging out together. And here you have more of them. Can you guys pick those out, the nevus cells? All these guys. So there was one of these in SurgePath yesterday, and sometimes because of all of the lymphocytes, the melanocytes can look really weird if you go in on high power and start looking at them because of all the inflammation. But this is a halo nevus, and so usually in a melanoma there's going to be a really, you know, a lot of times large lymphocytic infiltrate, because the body is pretty good at recognizing what's bad. But Dr. Elson describes it as more of like the riot police. So you have the melanoma, and then the lymphocytes are the riot police that are around the edge of it, versus almost never in a melanoma will you get the lymphocytes that are intermingled with the melanocytic cells like this. So this, you know, they're all mixed in there. There's nevus cells and lymphocytes kind of all scattered in together, and that's good for a halo nevus.
Is it like a cocktail party?
Yeah, cocktail party. They were invited to the party because they're friendly. Yeah, there's kind of all kind of nevus cells mixed in there. And sometimes if you get it towards the end, there aren't that many nevus cells. They can be really hard to see. Like the one that was in SurgePath yesterday, they were really kind of hard to find. Sometimes in intradermal nevi, you can get these nuclear pseudo-inclusions, which I think can be helpful in picking out the melanocytic cells. It's basically similar, I guess, to what you guys see in the papillary thyroid carcinoma. It's like the pseudo-inclusion, where it's basically the cytoplasm that's up in the nucleus and the way it's processed. So you can see that in intradermal nevi, and I think it's helpful sometimes to pick out the nuclei of the nevus cells when you have a really robust inflammatory response. Okay, so that one was just the halo nevus. 11. This one's big. So you, first of all, a lot of times over nevi you get a seb-like looking epidermis, which is what you're seeing here. You know, you can see the little horn cysts, and it's just sometimes seen with nevi. This one you can really kind of get an idea for what it looked like clinically. This was probably one of those lumpy, bumpy type lesions, you know, that I was talking about, because you got a lot of papillomatosis of the epidermis, and you know, you've got nevus cells that are totally filling the papillary and superficial reticular dermis, and then you know, there's really deep infiltrated nevus cells, which is kind of characteristic of congenital nevi. A lot of times they'll involve, you know, the upper 2/3 of the dermis, and you can see, you know, they're all around this hair follicle here. think in this one I tried to find an erector pili to show them being in it, but I didn't see it. But they like the blood vessels too. You see these guys down here. This is another congenital nevus. So all the cells are, pretty bland, and they're all similar to their neighbors. See if we can find some actually in the follicles. There you go. See, they're just sort of intermingled there. Pretty classic for a congenital nevus. No erector pili, but just like how they're hanging out in that sebaceous gland and that follicle, they'll do that with the erector pili muscle. So this one, if you look at it on low power like this, it also looks pretty well circumscribed, right? I mean, here's the end of your lesion, and it's got this little sort of collarette around it. And then if we go over to the other side, again, it ends, pretty abruptly. It's like they got this thing out. And, looking at it, this one has a lot of those artifactual clefts where you've got, just basically where it kind of tore and then the nest separated out. So let's look and see if we see their bodies. Looks like maybe you're starting to want to form one there. Starting to maybe want to form one there. I told you guys it's basement membrane, right? If you stain it, it'll stain with PAS. But with bodies. And then, see if we can find one that's less torn up. Okay, and then looking from top to bottom, kind of big nest of cells as you're going down, they're maturing, right? They're getting to be smaller nests, and the nuclei are getting to be smaller and smaller and smaller, which is a reassuring sign. More maturation. I'm trying to find a nest just to look within, but they're all kind of torn. We'll look in this one. All the nuclei are pretty similar in size. I think they're just, this one's maybe cut a little bit thick. This is just another Spitz nevus. Has all the friendly features we were talking about. I think a lot of times, clinically, if we get a read as a Spitz and it's not all the way out, like if it was transected, we'll go back and just get the rest of it, because I think the concern is if you did the biopsy in a kid, and only got part of it, and it grew back and somebody else biopsied it later, it's going to look really funny if you re-biopsy a Spitz. And, the concern is that then it would be overcalled and they'd end up with unnecessary surgery. So a lot of times we will. But it gets tricky because a lot of times these things are in kids, first of all, and then they're also, often on the nose or the ear or the cheek or somewhere that's cosmetically sensitive. So it varies a lot from provider to provider. I mean, they're benign. You're not ever going back and taking more because you're worried about it and sending a true Spitz. Just some people will because of the concern of regrowth. But I think if you counsel patients well and on that, that's another option. I mean, some people don't go back; they just talk to them about it. So there's a lot of provider variability for that one. But we see in consultation, Dr. Mays gets a lot of melanocytic stuff that ends up being called atypical Spitz, where we had one the other day where it's, asymmetric, doesn't follow the rules of the nice symmetry, and, full of mitoses in the deeper part, which you don't like to see, but isn't overtly a melanoma. So a lot of times with the atypical Spitz, they'll specifically put in there, like, recommend re-excision to tell them how concerned they are about it, basically.
Although the majority of them behave well, there's still a cluster that...
Well, and the whole thing is, like, there's... People say that there's better, prognosis, or they used to say that there's better prognosis for pediatric melanoma, but probably it was because a lot of the pediatric melanoma were Spitz nevi that were being called melanoma, and that was what was improving the survival curve. And I think as they've gotten better about sorting that out, pediatric melanoma more closely mimics melanoma in adults. So it's sort of the same thing with the proliferating dermal nodules and congenital nevi. Sorry, I need to hurry. But so there's just an article we read in Journal Club out of the JAD, which is our journal for dermatology, and it was basically saying that melanomas in these big congenital nevi do better than nodular melanomas, and probably I think it was comparable to superficial spreading melanomas. But then based on depth, they're like they do great because they're all deep, right? So they're like they do much better than standard melanomas. But you wonder, like, is that because some of the things you're calling melanomas were really not melanomas? Because the dermal proliferating nodules are like full of mitoses and they look like a melanoma. So it's just kind of hard to sort it out, especially in that population.
Well, both Spitz and blue can go to the lymph nodes, and it doesn't.
Exactly. Yeah. You can see Spitz in lymph nodes. Okay. So this one, we're on mucosa, right? There's no granular layer, and the kind of more pinky, flattened out looking top to the keratinocytes. And there's a better cut of this. Yeah. So a bit of acanthosis of the epidermis, but kind of what stands out to you the most is just the hyperpigmentation of the basal layer. It's a little bit more prominent along the tips of the redi, with all of this just hyperpigmentation. So this is good for a melanotic macule, and so you can get these in different locations. You can get them on the vulva. We see them a lot of times on the lips. People come in and worried about them. So I don't know where this one was from, but probably their lip. But they classically, they're going to be on the mucosal surface, and then they're going to have this basilar layer hyperpigmentation that's more accentuated around the tips of redi. So that's what this one was. I think there are 2 parts to this one. Yeah. Okay, so doing the same thing, looking at circumscription. So this thing trickles out to both edges, right? You can see the melanocytic proliferation heading out there, and then you can see a melanocytic proliferation. Where did my arrow go? I lost it. Alright, well, that edge. And then, so if you're looking at this thing, it's not behaving in a regular manner, right? You've got kind of random larger sort of nests of cells. The redi pattern is a little bit attenuated. You can see confluence in areas like, I don't know why I struggle with this arrow so much. There we go. So you've got, a bunch of melanocytes in a run there. A lot of confluence, actually. And then some of the melanocytes are kind of floating up a little bit higher. And so when we look at Clark's nevi versus, melanoma in situ, in Clark's nevi, the melanocytes are going to be along the tips and sides of the redi, but they're pretty good about respecting that. They mostly stay tips and sides. They can get kind of high up the sides, which kind of makes you want to look a little bit closer, but they're usually going to spare the arch. And so in melanoma in situ, first of all, a lot of times you have complete effacement of the reedy ridge pattern, so you can't assess that. But when you do have reedy that are left, they're usually, in melanoma, they're going to involve the arches. And this one, it just pretty much involves everything. You do have some attenuation of the reedy, but you can see, they're just melanocyte after melanocyte after melanocyte, and they're stacking. Like there's a melanocyte stacked on top of a melanocyte. And Dr. Elson talks about this. It's not as good, and maybe through here, but this sort of flat-bottomed red fibrosis you can see. You can see that in proliferations along the DEJ, including MIS and AK. So a lot of times in really sun-damaged skin, if you have clearly that flat-bottom red fibrosis and some sort of atypia and proliferation along the DEJ, a lot of times they'll get staining. It's going to be hard sometimes to sort out whether it's a subtle MIS versus pigmented actinic keratosis, which can both cause that change. So this one has a MART1, to go along with it. Which I think here, they tend to use the melanoma, panel that they have is levels in the SOX. The SOX being a nuclear stain, it's a little bit more clear to delineate, number of melanocytes versus with the MART1, you're getting, it's going to get into the cytoplasm and the dendrites as well, which is going to make it look like there's a lot more than there really is. So you have to kind of go in and look at it a little bit closer. But to me, this one kind of nicely highlights some of the pagetoid spread. You've got cells floating up where they don't belong, which is helpful. And you can see how it's kind of staining all the dendrites of these melanocytes, which make it look like there's more confluence than there probably is. But there's a lot of confluence in this one because it is a melanoma in situ. More float. We see a lot of melanoma here. I don't know if it's just because, in general, that melanoma incidence is increasing, or because we're in South Carolina. Probably both. Dr. Mays was saying the other day that, they rarely saw melanoma when he was in training, and now it's like an everyday thing. So this one was labeled as a pigmented spindle cell nevus of Reed. And again, some people do not delineate. Some people, Spitz nevus. But in Whedon, they say, whereas the Spitz nevus is the spindled and epithelioid, where it's usually a combination of the two, the pigmented spindle cell nevus of Reed is spindled. So it's going to be more spindled cells and fascicles of cells. And they still can have the communobodies. The architecture is going to be similar. They still have everything else is the same. They're very similar. Clinically, these are a little bit different in that they usually tend to be, I think of them as like proximal extremities, like thighs or arms, and they're going to be a sort of a jet black, really dark, papular macule, and sort of a younger person, like, somebody in their 20s, versus Spitz, you can see all the way up to early 30s, but we classically get them in younger people and kids. So, again, this one is tiny. It's really well circumscribed. A lot of melanophages, but you have the same clefting that we saw in the Spitz nevi we looked at earlier. Maybe that's not a great communobody. I didn't mention too that you can have, so these are going to usually more of a superficial lesion. With the Spitz nevi, you can have, just like I told you, you can have just intraepidermal Spitz nevi, you can have just dermal Spitz nevi. And if you go in and look at them on low power, to me, they kind of always look spitzy. And then if you go in, they have the prominent nucleoli, and they're clearly melanocytic. I think to me the hardest thing to distinguish the purely dermal Spitz nevi from is the epithelioid histiocytoma, because those epithelioid cells look really similar. So none in that cut. Yeah, so this one was called a pigmented spindle cell nevus of Reed. Alright, I'm going to try and go super fast for these. So, somebody wanted this out, right? This is a huge... either the biggest like shade biopsy I've ever seen, or an excision. And even from low power, you can see this is what I was talking about in terms of the effacement of the reedy. I mean, there are no reedy left, and there's just, you can see from this power just confluent melanocytes. So there's obviously a melanoma in situ component to this. This one also had a desmoplastic melanoma component to it, which is very subtle. I feel like they're more, it's usually a little bit more obvious. Sorry. This looks like scar.
Scary.
I mean, you would unequivocally stain this with a SOX 10. Because scars can be S100 positive too, so it can be hard to delineate. But what I would say is, if you ever, one would hope you get one that's a little more obvious. But like if you're in your SLAM differential and you have this, spindle cell neoplasm slammed up against the epidermis, you think about spindle cell squame, leiomyosarcoma, AFX, and spindle cell melanoma, or desmoplastic melanoma. If you ever get that on a standardized test, they're usually going to give you something else that helps you to point to what it is. Like this one, there'll be like a blatant overlying MIS, right? And so that will help you.
And that thing that is not very specific, it's a lymphoid aggregate.
Yes, yeah. So, yeah, because lymphocytes are really good dermatopathologists, and so they go after things that are bad, and so you really want to look, that should kind of scan key you in that there's something going on, and to look a little bit closer. So this one is a variant of a blue nevus called a cellular blue nevus. So it again kind of has the wedge-shaped architecture like the DPN we were looking at, but in the DPN, the vast majority of your cells were those sort of spindle dendritic melanocytes, melanophages, and only a few of the little epithelioid cells. This one, you can see the scan has more of those kind of epithelioid cells, or the light, I should say not epithelioid, but just the lighter colored cells. And with the cellular blue nevi, the base of them is pretty characteristic. They have kind of this pushing border. Like, it's not infiltrative, it's just sort of a bulbous pushing border, and it's often going to go down in the deep dermis or subcutaneous fat. So that can be a helpful clue. And then when you go in on higher power, you can see those cells I was talking about on lower power, right? So you have a mixture of cells. You have some of these, you have just melanophages, but then you also have some of the, pigmented spindled dendritic melanocytes. Here's a really nice one here. See the nucleus and the little kind of boomerang arms going out. So just like we saw in the blue nevus, right? But then you also have this larger population of melanocytes that are kind of epithelioid looking. And I think you can have different variations in numbers of each, but the fact that you have so many of these, it's really cellular, and that characteristic sort of pushing border is good for a cellular blue nevus. There's a variant of blue nevus called an epithelioid blue nevus, and that is seen in Carney complex, so it's pretty rare. I don't know if you guys have to know about Carney complex or not. We did in dermatology, but I would think probably not for pathology. They're the ones that get like the atrial myxomas and all. So maybe you do.
The land name.
Oh wait, am I? So I think it used to be. Some people called it name, some people called it lamb, and now they've merged it into one. Okay, so this one's a balloon cell nevus. They reserve the name balloon cell nevus for when the balloon cells are making up more than 50% of the nevus. You can also get balloon cell melanomas that are usually going to have bigger nuclei and have more mitoses. This one has more traditional nevus cells up top, which clue you into what the original pathology was, and then this kind of bizarre change, which is good for a balloon cell nevus. Yeah, it's I remember it as Parkicar, Carney's Parkicar, like PRK, like it looks like Parkicar, the gene, and yeah, they get a bunch of nevi and atrial myxomas, lentigines, blue the nevi a lot of times are blue nevi, which are specifically epithelial blue nevi. In addition to, they can get like the cutaneous myxomas too, and the atrial myxomas, and they can get testicular tumors, and they can have some endocrine abnormalities. So this is another pigmented spindle cell nevus of Reed. This one they barely got around it, but a scan, for me, these are more useful. It's almost easier to do these at scan, I think, because you can see a lot of the components at scan. So overall pretty well circumscribed. You have, again, the artifactual clefting around the nest of these spindled cells. If you went in on higher power, you'd be able to usually find their little camino bodies. This one doesn't go very deep. And if you look closer, you can see that there's maturation. A lot of melanophages. The pigmented spindle cell nevi are not as deep as this nevi. So maybe where'd you go? There's a little camino body there. So just another pigmented spindle cell nevus to read. This one I thought was really cool because it really nicely demonstrates the difference. So this was a melanoma developing in a nevus, and so, like over here you have your more traditional, nevus cells, right? Kind of right within the superficial papillary dermis. You have nevus cells, and then as you go down, they're maturing. This arrow is so light, I keep losing it. So here you have nevus cells, and as you're going down, they're getting smaller nests, and they're becoming, singlet. And then as you move over here, you're starting to get more of, what they refer to as nest upon nest, right? It's just basically sheets of cells. And then as you come over here, you really see that. I mean, there's no maturation at all. And whereas over here, you still have a nice preserved reedy architecture. As you get over here, this is basically just smushing the epidermis, right? You have effacement of the reedy, and the cells are just, smushed up against it, totally effaced. And if you look from top to bottom, there is no maturation whatsoever. And you can even see at this power that if you look horizontally across, the nuclei all really look different. They're pretty pleomorphic, going all the way to the base of this thing. So this was a melanoma developing in a nevus. And there's a lot of variability depending on what book you read. Some books say 30%, some books say 50% in terms of number of melanomas that arise from pre-existing nevi. I use 30%. That's what I tell patients. Basically a third of melanomas are going to develop in a pre-existing mold, the rest are going to develop as a new spot. So this is a nice example of one developing in the background of a nevus. And then the template that we use here for melanoma, they have, to delineate those that are associated with a nevus and those that aren't, even though there hasn't been any implication in terms of prognosis. So this is just another friendly nevus. We see these all the time in sign out. I think sometimes, so a lot of times we have them that have been traumatized. I think people pick at these or they like rub on stuff, and so you end up getting sometimes sort of this look to the superficial papillary dermis. But again, if you look at this thing, it's a polypoid lesion. It's out. It's well circumscribed. The lesion, the cells are, have bigger nuclei up here, and as you move down, you can see the nuclei are getting smaller. Here they're in bigger nests, slightly smaller nests, even smaller nests, and then singlet. I mean, you just go through that every time, and it'll help you decide what's good and what's bad. This was just a benign melanocytic nevus. The hardest part really is determining what's a Clark's nevus versus atypical melanocytic proliferation versus a normal. You guys have to go. Getting close. So this one was a Clark. So this is basically the daily challenge in sign out is determining what's a Clark's. But again, so in Clark's when we talk about a shoulder, it's talking about the fact that the epidermal component will extend out further than the dermal component, so that's a shoulder, and you do see that in Clark's nevi. And so you can see that, we got the epidermal component here is kind of trickling out, and that's the end of the dermal component. So this one does have a shoulder, and you get bridging very commonly in Clark's nevi, which you can see kind of all through here. You get sort of a fibrosis of the papillary dermis in Clark's nevi. The cells can look pretty funky, but again, the nests are going to be along in the base of the rete and up along the sides, but they're going to spare, the suprapapillary plates like here. They're not hanging out above in the arches. They're staying at the tips and sides of the rete, which is reassuring. Some people call them dysplastic nevi. I wouldn't do that here. There are two different kind of schools of thought about them. And some people still grade them, but basically there's not great inter-observer consistency with the grading. This one's just another benign, friendly nevus. Demonstrates all the things we've already talked about. Go on. This one was cool because basically this one's in here just to point out the fact that you can get some kind of neural change in nevi. So clearly you can see the normal nevus cells up there superficially, but this area is pretty good. If you go in on higher power, the nevus cells have become neurotized. Right, so they describe them as sometimes almost looking like little Meissner's corpuscles. I think that guy is a really nice example of kind of mimicking that. So just a neurotized nevus or neural change in a nevus. You can get a lot of different changes in nevi. You can get ancient change in nevi, or you can get some big funky looking cells. Last one. So this one, you can see the nevus cells, filling papillary dermis, and some down around adnexus. This is probably congenital nevus, but this one they really just wanted to point out the seb-like architecture. So the horn kind of looks like a sebby horn. You've got a lot of papillomatosis and kind of these like pseudohorn cysts. So if you didn't have the nevus cells, you call it a seb, right? So just pointing out the fact that you can get SK-like architecture in these nevi. So again, benign nevus. That's it.
Thank you.
Do you guys have questions?